I'm going to cover the chapter on diet, vitamins, and supplements. So many people are taking various dietary items, supplements, vitamins, different types of vitamins. Now the latest thing is peptides, with RFK Jr. being our health secretary. So you have to realize as a physician or a patient that many people are on this, and the U.S. is spending in the area of $30 to $50 billion a year on these products, according to some information that's available. I'm going to talk about calcium a little bit. The FDA recommended calcium intake is about 1,000 to 1,300 milligrams a day. The recommendation for vitamin D is generally 600 to 800 international units a day. This amount may be included in multivitamins, but generally is not. So milk products are recommended to supplement this. But also calcium and vitamin D will be needed separately, especially in women, to try to avoid osteoporosis and osteopenia, or thin bones and fractures. Excessive amounts of vitamin D can cause toxicity. Excessive amounts of calcium just is excreted in the urine, and the patient may get kidney stones with that. So you have to be careful with that. There was a case described of a patient who was taking 150,000 international units of vitamin D a day and got into some serious problems there. Now, this information is indicated for the average patient, not people with malabsorption or weight loss surgery, or malabsorptive disorders. So those patients tend to have more malnutrition and vitamin deficiency. I'm going to talk a little bit now about thiamine. So thiamine has come into focus for medical legal reasons and with lawyers, because it's more common than we thought. And it's not just occurring in alcohol or alcoholic type of patients. It can occur in other patients as well. And if you don't think about it, then you'll never make that diagnosis. I ended up seeing one patient with this in the hospital that I recognized. She had a complaint of double vision, and that's a very serious complaint, and it was a new complaint. And so went ahead looking her over further, I examined her and noticed she had nystagmus, which is abnormal oscillation of the eyes when you move your eyes to the right or left. And this was an important sign. I wanted an ophthalmologist to see her, but they don't come to the hospital. Fortunately, we did have a neurologist available. He did see her. We did do the blood levels for thiamine. They were low in the meantime before we got that back, and it takes several days to get that back. The patient was treated with thiamine, and the dose recommendation really has gone up from what it was in the past. So it's important to look over that if you're a physician. This patient was treated with intravenous thiamine, and I noticed at that time there were a number of lawyer advertisements on TV having to do with thiamine. A number of years ago, there was a lecture by a senior gastroenterologist who basically told our group in gastroenterology that we had failed to check vitamin levels and keep up with the problems that our patients had. So the special patients that need attention are ones with malabsorption, like pancreatic insufficiency or chronic pancreatitis, patients with Crohn's disease or bacterial overgrowth, and especially the bariatric cases that have bariatric surgery. In bariatric surgery, there's restrictive type of surgeries where the stomach is made smaller, and there's malabsorptive, and there can be combinations of that. Well, the malabsorptive types are particularly prone to vitamin deficiency. So you have to keep that in mind. But anyway, we were tasked with basically checking vitamin levels and a number of blood tests once a year, and just a comprehensive metabolic panel and a blood count every 6 months. So the testing included iron testing, B12, thiamine, magnesium, calcium, vitamin D, folic acid, vitamin E and A, zinc, selenium, vitamin K, prothrombin time, CBC, and comprehensive metabolic panel. So it's quite a bit of work, but it was done once a year. What we found, and what I found, was a number of people had iron deficiency, thiamine deficiency, vitamin D deficiency, low vitamin A levels, and these all had to be corrected and treated. Otherwise, there were some serious complications from that. The iron deficiency anemia had to be corrected, but also looked into why the patient had that. So they may need endoscopic procedures, they may need a CAT scan, because there's a part of the stomach you can't get to with the endoscope, and they may need a small intestinal evaluation, even though it may be expected with gastric bypass that they should have iron deficiency. I'm going to talk next about magnesium. Magnesium is a big problem because the magnesium levels may not be checked, and it's not checked as part of a basic metabolic panel or a comprehensive metabolic panel. It has to be ordered separately unless that's been changed, and I don't think it has been changed. And the problem is that you will not be able to correct a low potassium level without correcting the magnesium level, and you will not be able to correct a calcium level that's low without correcting the magnesium level. So you have to recognize that that may be going on and check for it and correct it. Magnesium has been used in a number of disorders that may be helpful even regardless of the blood level. And part of the issue with magnesium is that deficiency may not be revealed by blood testing because a lot of magnesium resides outside of the bloodstream. So it has been helpful in asthma, migraine, dyspepsia, and constipation. And finally, I'm going to just mention that there are a number of medications or drugs that can cause various vitamin deficiencies. I'm going to mention a few: isoniazid, cycloserine, phentoin, Tegretol, levodopa, theophylline, hydralazine, penicillamine. And there the issue is usually vitamin B6 deficiency or pyridoxine. So you have to be aware that some medications can cause various vitamin deficiencies and be alert to that. And with that, I'm going to conclude that particular chapter.